Medicine in 1974 from the University of Manitoba. Murray's in private practice, but he's also a researcher and clinical associate professor in the Department of Medicine at the University of Calgary Medical School. He has published numerous peer-reviewed scientific papers, presented lectures on research internationally at universities and professional symposia. His primary research focus is on the release, metabolism, and pathophysiologic effects of mercury from dental amalgams. And he has also served as a scientific consultant for the World Health Organization, a member of the 1989 Task Force on Inorganic Mercury in the Environment, and also as a consultant to Health and Welfare Canada. He's received fellowship degrees from the Academy of General Dentistry, the IAOMT, and he's currently on the board of directors of the IAOMT, of which he was a founder and first president. So it's a great honor and privilege to present to you Murray Vimy.
Well, good morning and welcome. So this is Washington. This is the first time I've been here, and it's a real pleasure to see so many people come out. The amalgam debate, is there still a controversy? Well, let me answer the question before we even get started. There is no controversy. From a scientific perspective, there is no controversy. From the political perspective, from the economic perspective, from the dental perspective, there remains a controversy. And I want to start out at the beginning to point out that the dental amalgam issue is not a dental issue. It is a medical issue. And the reason that it's a medical issue is because dental schools and the dental profession don't have the infrastructure or the expertise to do biomedical research. They have the expertise and the infrastructure to do excellent dental research. The kind of things that are being shown about the safety of dental amalgam entails large cadres of physiologists, bacteriologists, anatomists, biochemists, which dental schools don't have. They have some, but not the infrastructure needed, nor the equipment. Nor do dental schools have the vivarium, where animals can be kept to do animal research. And this is why I find it very interesting that in the ADA news and in the newspapers, people from the dental profession criticize research that's animal-based and say that it's not applicable to humans when medicine operates on an animal-based model. The Food and Drug Administration operates on an animal-based model. And if things do not pass the animal model, they are not licensed for human use. And this goes for a variety of things, from drugs to food additives to women's cosmetics to solutions that we use in contact lenses. It seems that the dental profession, when it's separated from the medical establishment at the turn of the century, although it has become scientific, there are areas that it just does not have the expertise. So the point I want to make is that this is not a dental issue. The research that I'm going to show to you today comes from our laboratory and a number of other medical laboratories, and the research has been published and peer-reviewed in the finest medical research journals. The FASF journal represents over 30,000 medical researchers on this continent who belong to the American Physiological Association, to the American Academy of Bacteriology, the American Academy of Biochemistry, etc., etc. For a scientist to get one article in his lifetime published in the FASF journal is considered quite an accomplishment. It's a good journal. It was ranked as the #1 medical research journal, greater than the New England Journal of Medicine. In fact, things come out in the FASF journal well 3 to 5 years in advance of when they come out in their human form in the New England Journal of Medicine. The editorial boards of these journals represent the finest scientific minds in medicine. And I have to tell you that medicine finds it quite humorous that the dental profession would make challenges and have people like Robert Barrett say that this research is published in veterinary journals. Those kind of statements do not bring credit to the kind of scientists that I know are in dentistry. So with those few words as a preface, now is there a changer here?
Should be up there. It's over on the other side.
Oh.
Robbie's over.
I got one.
How many milliwells?
Well, the university bought it for me, so I pretty much have to use it. If we could have the lights. You want to turn on the slides, please? Just turn the switch on.
So there's a problem, there's no slides, and the slides are there.
Are those your slides right there?
Sorry for that. But I and my colleagues are well aware of over 10 medical schools now on this continent and some in Europe that are actively doing research in this area.
With amalgams?
On amalgams and the implications to human health. And the laboratories that are involved in this are very sophisticated medical research laboratories, and this issue is not going to go away. And so, you know, what I'm hopeful is that somehow the American Dental Association should do what it was supposed to do 10 years ago and start taking the issue a bit more seriously. Is it coming? A bit more seriously in terms of the impact of what's going to happen. You've had the University of Georgia, you've had Tufts New England Medical School, you've had our university, which is one of the finer medical schools in Canada. You have research now that will be published soon coming out of Sweden in the next couple of months. All on aspects of this problem, all being published in peer-reviewed medical research journals. And so the ball is rolling. And I think back in the early 80s, when Dr. Savare and others started to show that mercury came out of the fillings in some kind of quantity that was certainly pharmacologic, that the dental profession should have started to look at amalgam with a jaundiced eye. I think it was Harold Worth, the very famous confrere of Pankey, who said you can't judge yesterday's dentistry by today's standards. And we have a material that's been used for 150 years, and it's still the standard. And I think we can't, continue this way. Just based upon the corrosion work that you've already seen this morning, it's quite obvious to everybody. In fact, it's quite obvious to any dentist who practice. Anytime you look in a mouth, you see corroded amalgams. Slides.
You were doing well.
I can ad lib, but it's not as much fun. I brought you your slides. I handed them to you. Okay, lights. All right, not too dark. All right. Anyways, I bring you greetings from the University of, and that you are prepared to live with whatever we find. All right. In other words, there are no preconditions based upon the money that this academy gives us. We thank you for that kind of participation. Because you see, when I started out, I actually started out to prove amalgam was safe. And I'm sure my friends at the American Dental Association and the Canadian Dental Association don't even realize that. I said, look, the dental profession can't be wrong. The people out there on the left wing who are be right. After all, I went to the University of Manitoba. My mentor was Dr. Izzy Kleinberg, the founder of oral biology. And I was trained to think from a medical perspective, from a basic science perspective. But when I did my literature search, what did I find? I found absolutely zero in the scientific literature, either medical or dental, to support the safety of amalgam. And in fact, in ADA materials up to about 1975, 76, they said that once the mercury was mixed with the amalgam, it was locked in and its toxic properties were made harmless. The mercury couldn't come out, even though that violates every law of physics and chemistry. That's what we've been told. Well, Now we know what comes out, don't we? And of course the argument is, well, it doesn't come out very much. There's very little coming out. It's less than fish. It's less. Talking about, and everyone should understand, those who aren't dentists, we're talking about the mercury fillings. These happen to be some pretty bad ones that need to be replaced. Anyways, the mercury fillings, as I prefer to call them. Why do we call them amalgam? We call them amalgam to hide the fact that there's mercury in it. Really, because amalgam means mixed with mercury. Amalgam means mixed with mercury if you're a dentist or if you're a material scientist. But the average person, if you said amalgam to it, they would just think it means something that's mixed together. But it specifically means mixed with mercury. And we don't even call it mercury amalgam. For the most part, it's called silver amalgam. But the largest component in these fillings is 50% mercury by weight in the initial mix. Why is mercury so dangerous to cells? Well, mercury is dangerous because mercury vapor in the air is rapidly absorbed across the lungs into the blood. All right? Blood mercury vapor is lipid soluble and can rapidly cross cell membranes. In other words, the mercury can go from the blood into any tissue. That intracellular mercury inactivates sulfhydryl enzymes. In other words, mercury is an enzyme poison, like lead, like arsenic, like bismuth. But the problem is, in that category of heavy metals, mercury is by far and away the most toxic. And CNS toxicity is more prominent if mercury is in the vapor form than if it's in the inorganic form. This isn't my information. This comes from Klassen and Goodman and Gilman's pharmacological basis of medicine, of therapeutics. And Goodman, by the way, is a Nobel laureate and professor and head of the Department of Pharmacology at Baylor University. What are the consequences of mercury exposure? Now, variations of the symptoms read like the who's of medicine, and this is the problem with mercury exposure. In fact, at low dose chronic exposure to this kind of heavy metal, it's actually impossible to diagnose it with any known test. Blood and urine are of no diagnostic value because the mercury does not stay in the blood long enough. It goes directly to the tissues. And this has been substantiated by research evidence, and we will see some of that later on today. And right now, in this present time, there is scientific international agreement on the fact that mercury is a highly unstable, volatile metal, that the major source of human exposure to mercury is dental amalgam fillings. The World Health Organization Expert Committee and every committee in medicine that's met has determined scientifically that the largest single exposure to the general population is dental amalgam. In fact, in the average person, dental amalgam mercury exposure exceeds all other environmental sources combined. But the American Dental Association tells us otherwise. And I'm not sure how they come to their conclusion. We know that it's scientifically agreed upon, even amongst the dental researchers, that mercury vapor is released from amalgam fillings by mechanical wear, by evaporation, by dissolution, and by corrosion. This is accepted by the medical people, as published in Fundamental and Applied Toxicology. A symposium of the American Toxicological Society had a meeting in Seattle specifically on dental amalgam mercury exposure. Drilling amalgams produces an exposure. And I think that there's a lot of dentists out there who are closet supporters of those of us who are prepared to stand up and step forward, who are taking out amalgams because it's good for business. Well, that's not why we're doing it. In fact, my business was better before I got into this issue. The issue is the health of our patients. The issue is, first, do thee no harm. Well, let's take a look at why mercury might be so problematic. And I think the previous speaker did an excellent job talking about corrosion and how mercury vaporizes, but simply comparing mercury and lead will give you some idea. And I hope people over here can see. If not, kind of pull your chairs over. All right. If you take a block of lead and a block of mercury, 1 gram, well, the mercury would be in a liquid droplet, and for 1 to 3 days you put it on a tabletop, nothing would happen to the lead. It would sit there. But in that time period, at room temperature, mercury would be vaporizing. Mercury, the only metal that's liquid at room temperature. That's why it's so wonderful. That's why it's in thermometers. That's why it's in barometers. That's why it's in pressure cuffs. It has this capacity. However, if you take the same mercury and the same lead and you place it for a tenth of an hour to an hour at 100 degrees C, now closer to body temperature, nothing happens to the lead. But the mercury, it's all gone. It's converted from liquid to vapor. It's converted to a form that's odorless, colorless, tasteless, and can readily be absorbed almost 100% across the lungs if you're breathing it. This is why high schools and hospital laboratories are dangerous places today, because of broken thermometers and high school experiments with mercury. This is why when dentists used to give kids a droplet of mercury to take home to play with, we know better now. And I, for one, do not understand why there's this debate. Because you see, in the Journal of Applied Electrochemistry, Gross and Harrison, dental researchers, reviewed the literature. Now, if you look at the wear of the different dental materials, there are experiments showing how fast amalgam wears. Every dental material researcher in the world will agree that this research is good. It's good dental materials research published in good dental materials research journals, and it shows that the average amalgam wears at 25 microns per year. What does that mean? Well, since energy can neither be, or matter can neither be created or destroyed but changed, the mercury, if it's being worn, or the filling material, the amalgam, if it's being worn off the tooth at this rate, it's got to be going somewhere. It doesn't just disappear. That violates physics. And so these people have shown experimentally that one occlusal amalgam filling, that's approximately 0.4 centimeters squared, will release 15 micrograms of mercury per day as vapor and as microparticles through wear. Ordinary wear that every dentist sees in his practice, that the dental materials people know exist, that most of them have done research on. So if a person had 8 occlusal amalgam fillings, it would be 8 times as much. There would be 120 micrograms of mercury per day released. This loss is by vaporization and mechanical wear through electrochemical mechanisms of dissolution. There can't be any argument about that. 120, those are the dental facts, the indisputable dental facts. Where's the stuff going? I could have had it be 8. Well, you see, we've been soundly criticized by the dental profession because our estimates are too high. Hell, our estimates are too low. Using their own data, the estimates are far higher than ours. Here, back in the early 80s, we did research, well known, this is where it all started, after Savare, looking at individuals who had 10 or more, 12 or more fillings that were a biting surface, those that had 4 or less, and those that had no dental amalgams. And what we did is we did the intraoral vapor test, because you see, if the mercury isn't in the blood, and if the mercury isn't in the urine, if the mercury is in the tissues, or could be in the tissues, the only way to assess exposure is to actually go to the mouth and assess it, just like they would use an instrument to assess carbon dioxide or carbon monoxide in the air. You can't ask for someone's brain cells. You can't ask for someone's kidney tissue to test for the mercury. So we want to see if indeed mercury came out. Because remember, the first fallacy was the fallacy that it was locked in. Was it locked in? Well, we took these subjects, here are the readings. Before chewing, the high amalgam group had a fairly low reading, the lower amalgam group had a low reading, and the no amalgam group had basically no reading. We gave them sugarless gum to chew. Something wrong with that? People chew gum all day long. That's a normal human thing to do, chew gum. And what we found is that there was a rapid rise followed by a plateau. And in fact, every 5 minutes what we did is we had them spit the gum out, we had them swallow, we did an intraoral vapor test, gave them a fresh piece of gum, and continued the experiment. At the end of 30 minutes, vapor level. You see that the people with 12 or more had significantly greater than 4 or less. In fact, when you do a correlation, you find that the intraoral air mercury concentration is proportional to the number of amalgams that they have that are biting surface. Others have gone further and shown that blood levels correlate with the number of amalgams in the tooth fillings, published in dental journals. And those Sorry?
About brain tissue?
We'll get to that. And those that had no amalgams showed no mercury in their mouth. Was that a surprise? I don't think so. Should we be surprised? I don't think so. But what were the criticisms? Well, the vapor testing machine's no good. It's biased. Or chewing gum is not a normal response. Or your calculations are wrong, your mathematics are poor, you did something wrong. But I just showed you that the amount of mercury that was coming out of those fillings on a daily basis was 120 micrograms of mercury per day just from 8 biting surface amalgams. Exacerbate the mercury release. I think the previous speaker identified many of them in terms of how it happens at the level of corrosion, but frequency of eating. In other words, if you eat more frequently, you're going to be on that roller coaster more often. Now, I'm going to go backwards here. How do I go backwards? There. The important thing to note here, and I wanted to make this point, is that after they stopped chewing, it took, and if you extrapolated this line out, it would take 90 minutes to get back down to baseline, to get back to the pre-chewing levels. Why is this? Well, I think chewing causes friction. And friction causes the free mercury, which has been shown to you, to vaporize. And until the dental amalgam fillings start to cool down, mercury keeps coming off, but at a decreasing rate. So, we are all on a roller coaster of mercury vapor exposure. We have breakfast, we get exposed, 90 minutes later we're just getting back to baseline, and it's time for coffee break. 90 minutes later after coffee break it's lunchtime. 90 minutes later after lunchtime it's afternoon coffee break, and on and on and on and on. But if you eat more frequently, like some people who have to eat every hour or so because of blood sugar levels, or if you're a chronic gum chewer, or if you brush your teeth a lot at night, or if the food is hot or very acidic, those kind of factors will make it worse. Acidity, as we were told already, causes corrosion. Don't drink the cranberry juice, or eat the pickle, or have a lot of salt on your food. In fact, dental amalgams are great, just don't chew it. So, what about mercury? Well, mercury in its vapor form is between 75 to 90% absorbed across the lung. So this odorless, colorless, tasteless mercury is absorbed across the lung into the bloodstream. In the GI tract, if you swallowed methyl mercury, such as would be found in fish and certain kinds of seafood, 80 to 100% of it would be absorbed. But if you swallowed a little gram of liquid mercury, only 10% of that liquid mercury would come off as vapor and be absorbed in the GI tract. And of course, some of the mercury is going across the nasal mucosa, the oral mucosa, and the skin, because mercury is nonpolar and lipid soluble. This is why dentists are trained for the no-touch technique. Don't touch the amalgam. Get it in that mouth without touching it. But don't worry about the tongue and the lips and the cheek inside that mouth. That's okay. Well, there are a whole slew of papers, and these are just some of them, published about trying to determine what the daily dose would be to mercury from vapor from these amalgams, ranging anywhere from 27 all the way down to Olson and Bergman and Makert of 1.24 micrograms per day. It is interesting that most of these at the bottom, which have been published in the JADA, are not even experimental. Basically what they were is they took my experiment, they added their own presuppositions, and they recalculated our data and came out with 1.24. Now I say to you, if their own evidence shows that 120 micrograms of mercury is lost per day from wear alone, how can they come out and then say it's only 1.24? I don't understand it. I don't understand how, and I don't understand why. So we wrote a paper, a review paper, reviewing all these so-called experts in biomaterials and how they said that amalgam didn't give off any mercury. In fact, Dr. Robert Barrett's to this very day, in fact last week he testified in court, said that there's no mercury in amalgam and it doesn't come out. He said this in court, under oath. But we published this paper, but we don't publish in dental trade journals. We published in peer-reviewed medical scientific journals. We submit our research to the highest scrutiny available. If we're talking about brain tissue, it's going to a brain journal. If we're talking about germs, it's going to a bacteriology journal. If we're going to talk about kidneys, it's going to a kidney journal. It's not going to a dental journal. Because the research has no validity if it's not peer-reviewed by experts in the field that the research is about. Well, one of our experiments, because you see the dental profession said, oh, this mercury, it's coming off, we agree with you, it's coming off, but you're wrong, you say this much, it's really 1/16 this much, and besides that, Dr. Newman in the ADA News said that we don't inhale it, we blow it out. All right, so this mercury is not going in. We agree with you, Vimy, some of it's coming off, but you know, it's blowing off. It's not getting into the tissue, all right? So we decided to do some experiments. One of the experiments we did was to see if you could actually visualize mercury in tissue. Now, the FASF journal is where these were published, and I told you about the FASF journal already, back in 1990. And this is in monkey. And what are the principles that we use? Well, what we did is we mixed the amalgam exactly identically to the way any dentist mixes amalgam to place into a patient's tooth, except 10% of the mercury in the mix had a very low level tag of radioactivity. This is the way science operates. When you have a cancer, they inject you with an isotope and take a whole body image scan of you to see where the isotope goes so they can identify the cancer and the metastases. This is done in every hospital, including small hospitals, everywhere in the world. This is nothing new. So we took a little bit of mercury-203, a little bit of mercury, and if you know how much radioactive mercury there is to how much cold mercury in the filling, in other words, it's 10 to 1, then you go to the tissue, and if you count the number of atoms of hot mercury, multiply it by 10, and that tells you how much to cold mercury there is. Now, hot mercury is not in the environment. Hot mercury has to be made in a nuclear reactor. So any mercury you find in the tissue can't be coming from food, can't be coming from background sources, can't be coming from anything else. It can only become from mercury that you placed in the teeth because it has to come from a nuclear reactor. Everybody understand that? Because the dental profession at large doesn't understand these studies, although they are very straightforward. And here we are, well protected, because these monkeys carry viruses that if you get, there's no known cure to. And so I'm taking a lot of risks doing this research, and no one's paying me for it, and I'm not complaining. But you should know that when you get into this kind of thing, there are risks involved, and there's here between these two species that can be fatal. And here's what you get. You get what's called a whole body image scan. This is a camera that's used to scan the body. Now you can see the outline of the monkey. Here's the arms, and the torso, and the legs, and the kidneys are up here, and here's the GI system, and the liver. Now, this is a whole body image scan of the monkey. 30 days after these radioactively tagged amalgam fillings were placed in their mouth with the same care that I treat my human patients. Now, I think I'm a fairly good dentist. Are there better? Sure, you can always find someone better. All right, are there worse? I think a lot of them are worse. But I took care, and I used skill, and I used judgment in placing these amalgams, because you see, I went out with the theory that I was going to show amalgams to be safe. But here's the mercury in the tissue. And you can see in this view, the kidneys show up very well. Is that new? No. The main target for 90% of mercury exposure from any source is the kidney. So what we found here is that for amalgam mercury is no different from fish mercury, really, is no different from occupational mercury vapor exposure. Mercury is mercury is mercury. And mercury will go where mercury will go. And we concluded that high accumulation occurs in the primate body tissues after amalgam placement, that the roots of mercury absorption and tissue concentration in the primates are nearly identical to a previous experiment we did with sheep, and that high mercury concentration is evident in the kidney, intestinal tract, and the jawbone. Monkey is exactly identical to human. Their physiology is almost identical. Their chewing pattern is cuspid guidance occlusion, and they have a diet similar to a human, and the feeding was controlled. They only ate 2 meals a day. And medicine bases itself on the premise that if it's true in monkey, there's a 99.999% chance that it's true in human. And if we take a look at some of the studies that have been published comparing the distribution of amalgam and mercury in these different kinds of experiments, you can see if you look at humans in the human experiments, and these come from Dr. Nylander's and Dr. Eggleston's research, you can see when you look at the general population with no amalgams, that their kidneys had a range of between 21 and 105 nanograms mercury per gram of tissue. And that the general population of people who had amalgams, that the kidney had a range of 48 to 810. So there is an increase. Now these are old amalgams. These aren't new amalgams. These are old amalgams. Other human studies, these were done also by Dr. Nylander, showed in the general population with unknown amalgam history that the range was between 22 and 808. And in dental personnel who have an occupational exposure, it was between 940 to 2260. And if you compare that with our monkey experiments and the monkey experiments of Dancher and the sheep experiments, you can see that all these ranges overlap. When you compare mercury-containing animals to non-mercury-containing animals or non-amalgam-containing animals, when you compare humans with no amalgams to humans with no amalgams, all these ranges here overlap. And mercury can also be found in brain tissue. And these are the means. And dental personnel had very, very high levels. And I would think, and I would hope, that dentists would be smart enough to stop using amalgam for no other reason than to protect themselves and their dental assistants. If for no other reason, we could do it. Now, 10 years ago, the alternatives may not have been available. Today, they are. I was at the Swedish Medical Research Council meeting, and the director of the Scandinavian Dental Research Institute says that he has on file valid experimental evidence showing that the composite restorations, on the most part, are biochemically safe using the kind of standard tests that they use. So as far as he's concerned, he's shown that these materials are safe. Yet, for some reason, you have some dental politicians saying that we don't know about the composites. They might be just as harmful as the amalgam. And we see this published all the time. And I say to you, how horrible that they would come out and say that, first of all, when it's not true, and how horrible would it be that our profession not only put amalgam on the market, now we're putting another material on the market and we still don't test it? And they think they're being smart by saying these things? What do you think medical professors think when they see this kind of stupidity being published? You tell me. Yeah, we got composite on the market, but it's got problems too. It's probably no better than the amalgam. What kind of thought process goes into that is what I want to know. And you know who's saying these things? People who aren't the real researchers. And you know who's writing review papers? People who don't do any research. If you want to assess a review paper to see how good it is, see if the author of the review paper cites himself. If he does, he knows what he's talking about, because he's a researcher and published papers. If he's Joe Blow, prosthodontist, never published a paper on amalgam, and writes a big, huge article on why amalgams are safe and cites everybody else, he's a nobody and doesn't deserve your attention. Okay, so the dental profession has been wrong with number 2. That the mercury is blown off, that the mercury doesn't get absorbed, that it doesn't go into tissue, because I've just shown you animal and human evidence showing that the mercury in retrospective studies in humans comes from the amalgam, and in animals prospectively it comes from the amalgam. A valid question which can be raised is, so what? Maybe the mercury goes there and doesn't do anything. Maybe the amount of mercury that's going there doesn't cause any harm. And if it doesn't cause any harm, what's the big flap about it? Well, in other words, does amalgam itself cause any pathophysiology? First question that one might want to ask is, does dental amalgam cause renal pathology? We saw that most of the mercury collected in the kidney, so obviously the first place that any thinking person would want to look is where he sees most of it, which is the kidney. And we published a paper in the American Journal of Physiology, which is one of the blue ribbon journals in medicine, where all the basic medicine is worked out first. We published a paper where we looked at mercury from dental amalgam and how it affected the kidney function of sheep. That happened to be our model. We use an inulin test. Inulin is used to determine how well your kidney is functioning as a filter. Think of your kidney, one of the functions is as like a car filter for oil. Lets the bad stuff out and keeps the good stuff in. And this particular test is used in every hospital on human beings, has a long track record for determining the ability of the kidney to act as a filter. All right? And we collected measurements and samples as an index of kidney function. We had 2 groups of sheep. One group of sheep, this is time in days after placement of amalgam, so these first two dots are before the placement. And this is the rate of clearance of the inulin. The faster it clears, the better the kidney's acting as a filter. Okay? The slower it clears, the more plugged up it is. Think of it that way. We had two groups of animals. One group of animals, we had ordinary, non-radioactive, plain Johnson & Johnson dispersalloy amalgam. Right out of the old capsules, right from the jar. No mixing, no mess, no fuss, put it in the amalgamator, pack it in according to proper protocol. And what you found is that if you compared before placing the amalgam to 30 days after placing the amalgam, that in the sheep model, there was a 50% drop in kidney filtering ability. And if you looked again 30 days after that, it was still down. On the other sheep that had the same kind of treatment, they were had fillings put in, but they had glass ionomer base cement fillings put in, there was no change before and after placing the amalgam. So within the confines of the animal model employed, we found that there was an effect. The effect was directly related to the experimental modality that we used, and that was the placement of the fillings. And the only difference between these two groups of animals was that one had amalgam and one had glass ionomer. Everything else, their food, their water, their handling, the anesthetic, everything else was identical. Right now, we have data collected but not published or compiled on monkey, because we replicated this experiment now in monkey, and we're getting some similar results, but not to the same extent, which is to be expected. We picked sheep because they were a chewing machine. That's why we picked them. In other words, if there was no problem in sheep, end of story. Science, or at least medical science, doesn't start with humans and see if it's safe for animals. Medical science starts with animals and sees if it's safe for humans. When they study brains, they use snails. One of our colleagues had a big paper written in Science, and it was a breakthrough study on how neurons regenerate, and his model was snails. Medicine takes that real serious. I doubt if too many dental schools would. We also found that several parameters in these sheep changed. Sodium. There was an increase in sodium in the urine. Here's before amalgam, here's 30 days after the placing of the amalgam, and here's 60 days after placing of the amalgam. And you can see that the number increases. In other words, the proximal tubule in these sheep was somehow being affected at the biochemical level so that sodium wasn't being reabsorbed. Think back to physiology in first-year dentistry. That's one of the functions of the kidney, to maintain sodium balance. So here was something coming from the teeth in this model that was interfering. We also noticed that the albumin showed a drop in the urine. Now, albumin is a molecule of 63,000 molecular weight, that under normal hydrostatic pressure in the kidney just barely gets over and a few of the molecules come across. But we showed in this experiment that after placing the amalgam, less of it came across. I want you to keep that fact in your brain for at least 5 minutes, please. All right? Albumin decreased in the urine in animals after placing amalgam. We concluded here that there was a 50% drop in the glomerular filtration rate in the sheep's kidney. This could be a result of reduced blood flow, and that the tubules in the kidney had some problem maintaining electrolyte balance in those sheep. Is this new? Absolutely not. Dr. Dancher in Scandinavia published a research paper in monkey where he placed amalgam. He showed that mercury from the amalgam accumulated in the proximal tubules for well over a year. So our work has been replicated. So if they don't like sheep and they don't like monkey, I want to know what the dental profession likes. I want to see their experimental evidence, because you see in science, if one scientist disagrees with another, he designs an experiment to prove him wrong. The debate goes on in the journal. The debate doesn't go on in trade journals. The debate goes on with evidence, with data. It doesn't go on with opinions and preconceived hypotheses. In rats, the proximal tubule is a primary site for mercury accumulation of the inorganic type. In fact, 60% of the sodium is reabsorbed in the glomerular filtrate in the proximal tubule. So the proximal tubule, where the mercury collects, is where the defect was. Another slide. Now you'll see in all my slides, I'm citing literature. I'm not giving you fact or hypotheses. I'm citing you experimental papers that are published in peer-reviewed journals. So if you look at the bottom of my slides, none of this is me. This is all medical research that's been known and in textbooks. But you see, Dr. Barrett, an advisor to the American Dental Association, said that millions of Americans have amalgam fillings, but there is clearly not an epidemic of renal failure in these individuals as the author of the sheep studies would suggest. We never suggested anything of the sort. In fact, in order to have renal failure, you have to have 90% kidney loss. And I'm sure there may even be someone in this room that operates on one kidney. In other words, nature has endowed us with lots of kidney capacity. So this kind of statement from a man who purports to be a physician and purports to be a PhD and purports to be a dentist and who in a 20-year history of being an academic has only published 6 papers, and none of them on amalgam and none of them on mercury and none of them in the last few years, begs the question. Dr. Sheldon Newman in the ADA News said that if amalgams had similar effects, kidney dysfunction in humans, we, being the dental profession, would have noticed it by now. I would think we would have noticed it, particularly among dentists who are exposed to mercury all the time and who have been using it for 150 years now. So I would ask you the question. Those of us who are dentists, are we trained to diagnose kidney problems? Do you know what tests to take? Could you do a differential? Then I ask you, how the hell are we supposed to see it? We don't even acknowledge the fact that there's corrosion, even though we look at it every day. We have to have a materials scientist who's not one of us, who can look at us and scratch his head and say, what's wrong with these guys? They look at us and they can't even identify it. Well, here's the interesting thing. I'm showing you the evidence in sheep. Is there evidence in humans that dental amalgam mercury produces a problem? And you know what? There is experimental evidence from a dental school published in a dental journal showing the effect. Moline et al. In Scandinavia in 1990 did a study with humans. They had 10 subjects who had amalgams, and they found that the plasma mercury level highly correlated with the number and total area of amalgam surfaces. This is humans now. 12 months after they removed the amalgam from all 10 subjects, the mercury in the plasma dropped by 50%, and the mercury in the urine dropped by 25%, and was statistically significant at the 0.01 level. Interesting. Okay? But more interesting, and what they didn't notice, and what they didn't even comment on, was that in all 10 subjects, 12 months after amalgam removal, but hey, we don't have a problem with dental amalgam. That mercury is inactive. It's just sitting there. Now, they reported the data, but this particular information was just a number in a table. And this happens in science. It's called the paradigm effect. You only see what your mind is prepared to see. Until Einstein came along, everyone believed that Newton had worked out all the laws of physics and that there was nothing to do except quantify the universe. All of a sudden, a little Jewish boy comes along with a different idea. He says, I have a different equation. I think reality is this equation. And all of a sudden, there was a paradigm that got busted. All of a sudden, everybody challenged him. All of a sudden, 10 physicists from Germany said that if Einstein is so right, we don't believe him, he's a liar, he left our country, he deserted Germany, the whole business. There was a whole scandal about Einstein. And Einstein was asked by reporters, well, Dr. Einstein, what do you feel about your peers from the German Physical Society saying all these nasty things about you? He says, all it takes to prove me wrong is one bit of evidence. Doesn't matter what these people say, I'll wait for the evidence. Well, ladies and gentlemen, the evidence is coming in. Now, as a profession, and not just us, we have a responsibility to our colleagues who are on the other side of this political debate to try and avail their minds of the scientific evidence and of the fact that they should slowly start to backpedal to protect our profession. Because a critical mass is going to occur, and somebody, be it the American Medical Association or some scientific body or some governmental body, is going to come down with a big hammer on top of the dental profession at large. We've been trying to open a dialogue for years. And hopefully our colleague here who works for the ADA might get this published, but he won't say anything of what I've said, I'm sure, with regards to the problem here. So the dental evidence is there to support the animal research. What more do you need? I mean, how much kidney problems do you have to have? Well, let's see what else happens. All right, we've identified kidney pathology as one pathology already caused by amalgam, substantiated by scientific evidence. And here's basically what happens. The mercury leaves the tooth, it's inhaled, it's swallowed, it goes to the lungs, goes to the liver, goes to the kidney, and does its damage. Plain and simple. Well, Dr. Mackert, I always get it mixed up. Mackert published a paper about immunology. Because you all remember Dr. Eggleston came out with this paper in the Journal of Prosthetic Dentistry a number of years ago saying that amalgams affected the immune system, and he only had a few subjects, and it was highly criticized by other dental peers as being a problem. So Dr. Mackert did a study, and he published it in JADA, Journal of the American Dental Association, on lymphocytes, where he took 21 subjects with amalgams and 16 subjects without amalgam, lymphocytes between the control and the amalgam groups for T11, T3, T4, T8, B1, and LU7 cells. And it was published in a trade journal, the Journal of the American Dental Association. Now, anybody here an immunologist? One. Should a dental journal be peer-reviewing immunology papers? I doubt it. If you've got an immunology paper, shouldn't you submit it to an immunology journal? I would think so. Dentistry is a branch of medicine. Exactly the kind of people it should have gone in front of the first place. Immunologists. And they said, first of all, people between the ages of 16 and 60, there's gender differences. There's also smoking history differences, and there's diurnal rhythm differences during the day, and depending upon when the cells were taken. All of these things are confounding factors that weren't controlled. They didn't. They went to JADA. Am I making this up? Hell no. All those factors can be found in the standard immunology textbooks, so that any standard immunologist would understand it. The subjects were not divided according to the amount of mercury vapor they were exposed to. We all know, those of us who do vapor exposure levels, that some people with a lot of fillings don't necessarily have a large exposure. Chewing pattern, age of the filling, the size of the filling, all these things are factors that may mean that someone has less of an exposure than someone else. There's a variance here. You see, his design is an unpaired design, so it's too great to allow comparison. In other words, he's not comparing someone before and after. But if you would have taken people without amalgams and placed amalgams and then taken the amalgams out again and used each person as its own control, then you don't have to have as many people in your sample. So personally, as far as I'm concerned, from a scientific perspective, this study produces absolutely no evidence of anything and should never have been published. And it makes us look bad to think that we, in our trade journal, can peer review and adjudicate immunology. Good dentistry can go in there, good dental science and good dental medicine can go in there, but dental schools don't have cadres of immunologists teaching dental students immunology and hematology and those things. We have other kinds of specialties. We have to start taking advantage of our medical colleagues and use them to help us raise the standard of care. We shouldn't be using a material that's 150 years old and produce scientific papers like this and tout it. And while I'm on the topic, a year or two ago there was a whole issue on dental amalgam with all the so-called experts in JADA talking about why amalgam was safe. And I'd say to you that any proper professional organization would first and foremost want to carry on a debate. They would invite both sides.
Amen.
Present your evidence. That's what journals are for. When you see a trade journal like JADA do what it did, smells fishy to me. Now, I don't know what the reasons are, and I'm not sure of the politics or the legal or whatever implications. All I know is that physician, first do thee no harm. Okay. Pathology, we've talked about it. Kidney problems. But you see, there's also a problem with mercury and Alzheimer's disease. At the University of Kentucky Saunders Brown Institute, a number of groups have been working on Alzheimer's. It's the fastest growing medical problem in the 20th century. And the cost and the care for these people and the personal suffering to families is amazing. Well, they took brains of people, some who were age-matched, some were controls who died of ordinary causes, some who died having Alzheimer's. Usually you don't die of Alzheimer's disease, but you die with Alzheimer's disease. And they examined areas of their brain, especially the nucleus basalis, which has to do with memory, to see if any of the metals, and they examined for all metals, any of the metals were different between the two groups. And the only difference in the Alzheimer's disease brains was the fact that of mercury. There was a statistically significant difference in the Alzheimer's disease brains in terms of they had a lot more mercury. And they said to themselves, well, where could this source come from? People in Kentucky aren't fish eaters. And there's no known massive exposure to mercury in the environment. And we do know that mercury affects memory. And we do know that the CNS is a target for mercury. And they didn't find a connection with aluminum. So they said to themselves, what's going on? Could it be the amalgams? Or perhaps seafood? But since there wasn't a lot of seafood eating, they thought maybe it was the amalgams. Well, they've since been given $1 million by NIH to examine the relationship between dental amalgam and Alzheimer's disease. Because as the use of amalgam has increased in the 20th century, so has the incidence of Alzheimer's disease, and then there's this little connection here with the cadavers. But if you think that this is bad, wait till you see the next slide. Because another group, under Dr. Boyd Haley, a biochemist, looked at tubulin. Tubulin is a polymer in the brain that's responsible for helping to lay down the neural fiber networks. In other words, if the tubulin system is working properly, you get nice, straight, properly connected neurons. If the tubular system is not working properly, you'll get neural tangles, which is the lesion of Alzheimer's disease when they examine the brain under a microscope. And what they did in vitro and in vivo, they were able to show that mercury, when fed to animals or from brains of humans, that it was mercury that was actually affecting the tubulin polymerizing and depolymerizing effect. In other words, they produced Alzheimer's disease in animals experimentally by exposing them to mercury. Well, hey guys, we're the third largest user of mercury on the planet. The largest single source of mercury exposure in humans is amalgam. Do you think that this warrants further investigation? Do you think that the powers that be within our profession should stand up and say, yes, maybe we're part of this problem. Let's correct it. Let's look at it. Let's support it. Let's fund it. Well, so now I've identified for you some pathology related to amalgam. Recently, some of you have heard and seen probably because the media picked up on it, a research study that was recently published by Dr. Summers as the primary author, Dr. Stuart Levy from Tufts University Medical School, members from our group, and several statisticians from the University of Georgia who helped us put the data together. Now, just to clarify this for you, this has to do with bacteria. So it was published in one of the main journals of the American Society of Microbiology. The journal happened to be Antibiotics and Chemotherapeutics. So we took the data to a reliable source. Who's Ann Summer? She's only the world's leading authority on mercury-resistant bacteria. Who's Dr. Stuart Levy? He's only one of the world's leading authorities on antibiotic resistance in humans. We're small players. We just help supply tissues and things for these people, for the big guys to analyze. Now, if the establishment isn't wakened up by a good old boy from Canada doing some research, then maybe they'll wake up when Tufts Medical School gets involved. I don't know what it takes. But what did we find? Well, there were two experiments. The first experiment had to do with humans. That was done in the 1980s. And 640 hospitalized patients and ambulatory donors were looked at, and from that was taken 340 patients, and they were all matched and age-controlled, and 95% of them were adults over the age of 15 years, and 56%, or almost half of them, were females. And what they found was a very interesting finding that was published as part of this paper. On this axis here is the percent mercury-resistant bacteria. In other words, the bacteria in the gut that were mercury-resistant. And on this axis is the percent of all human subjects that showed the resistance. The dark bars are resistant to 2 or more antibiotics. And the light bars are those that showed no antibiotic resistance. So you see that as the mercury resistance increases, the number of people that had no antibiotic resistance decreased, or stayed the same basically. And as the percent of mercury resistance increased, the antibiotic resistance increased. So in other words, as you go from 0.001 to 100, in other words, as the number of bacteria become more mercury resistant, they also become more antibiotic resistant. And when you do a correlation coefficient on that, that's exactly what you find. A very high, strong, positive correlation. So in humans, antibiotic resistance and mercury resistance seem to go hand in hand. And look, you have these two factors that seem to be related. As mercury resistance increases, antibiotic resistance increases in humans. We don't know why, but this phenomenon exists in a substantial experiment. Let's do an experiment in monkey where we can put in amalgams and check before and after placing them to see if the mercury is having an effect on the antibiotic resistance. Could there be a connection here? And we had several sets of experiments. We had 3 sets of experiments. Each experiment had 2 monkeys. All the monkeys were wild captured, so they were right from the wild. They were never exposed to mercury or to antibiotics of any kind. And the experiments were such. The first experiment, we took samples of their oral cavity bacteria and their fecal bacteria prior to placing the amalgams. Then we placed the amalgams and we continued to take samples for 5 days. In another experiment, we got a baseline before placing the amalgams, put the amalgams in, ran the experiment, kept taking samples, and then at about 9 or 10 days after placement, we took out the amalgams and we continued to take readings to see if taking out the amalgams had an effect. And same in this one, except we just extended the precondition a little longer. So the experiment was comparing mercury resistance and antibiotic resistance in oral bacteria and fecal bacteria over time, before, during, and after amalgam. And if you look at the average fecal output of mercury for the 4 monkeys that in one part of the experiment, you can see that prior to placing the amalgams, where these negative numbers are, there was dropping off over time. And you can see again here at about day 9, when we took the amalgams out, the removal of the amalgam produced a large exposure again, which fell off almost immediately, which is what we expect and what dentistry knows from its own research. So mercury in the fecal material only showed up after placement of the amalgams, subsided, and then only showed up again after removal of the amalgam because of the exposure due to removal. Nothing astounding there. We then looked at the time course frequency of mercury resistance in monkey fecal Enterobacteriaceae. Here's the mercury resistance prior to placing the amalgam. There are a few bacteria that have this gene, and if you do an experiment, you find that they're there. But you see, at day 0, after placing the amalgams, there's a rapid rise of mercury-resistant bacteria, and then it slowly drops a little bit until after the amalgams were removed in this group, and then it peaked again. If you look at the time course frequency of mercury resistance in monkey fecal enterococci and oral streptococci, the light bars, you see the same effect. Prior to placing the amalgams, the mercury resistance was extremely low. After placing the amalgams at day 0, bacteria. That's why they put it in pink. That's why they put it in contact lens solution. That's why they put it with inoculations. So they put it these places to keep funguses and bacteria down because it kills things. All right, if we look at the frequency of antibiotic resistance now, again, after amalgam removal, in terms of mercury resistance, or in terms of antibiotic resistance. And the antibiotics that were used were tetracycline and ampicillin, 2 very commonly used antibiotics. Now remember, these bacteria, these monkeys in the wild, other bacteria didn't show any effect. For instance, if you look at the time course frequency of tetracycline resistance in monkey fecal enterococci and oral streptococci stayed the same, and there was a little bit of a change in the other bacteria. So some of them changed and some of them didn't. Why is this important? Here's why. Some bacteria have a little tiny piece of genetic material called a plasmid. On this plasmid is encoded information for certain kinds of things. It happens to be that on a plasmid there's a code for mercury resistance. So that if the environment has mercury in it and it triggers this cell, what the cell does is that it turns on the operon for mercury resistance. That gives that cell new enzymes to use, which it can use to help get rid of the mercury from itself. So it's a protective mechanism. It then copies that little plasmid and passes it on to another one.
Not through replication of the whole cell, but it takes it and actually says, here, I just got exposed to mercury. You need it too. Take this. And so what happens is that all these bacteria start to pass this plasmid around while there's mercury in the environment. Everybody follow? On that same little plasmid, right next door to mercury, guess what sits? Ampicillin, tetracycline, penicillin, all these antibiotics are also, for some reason, encoded on the same plasmid. So mercury exposure means that mercury is a natural selective mechanism to pass information from cells, not only to keep them safe from mercury, but also to keep them safe from antibiotics. So if you've got dental amalgams and you're getting a significant exposure, the importance of all this is that patients that have infections, medicine is finding antibiotics aren't working. And they thought maybe it was just because there's antibiotic exposure. This is the first non-antibiotic factor that's been identified in the world that could produce antibiotic resistance. Is that important in medicine? Well, let me tell you how important it is. It's so important that the journal Science published an entire issue on antibiotic resistance. They didn't know about this study at the time. November of 1992, an entire issue of Science is devoted to antibiotic resistance. It's a growing problem in medicine today. You've got all the syphilises and the gonorrheas and all these things that are coming along that are resistant. And this is one of the reasons, the first non-antibiotic reason, and there'll probably be a lot more, that since 85 to 90% of the Western civilized population is medicated with dental amalgam, it might prove to be an important one. That remains to be seen with further research. Is this pathology? Yes. Before the mercury even gets into your body, because remember, your GI tract is not in your body. Your GI tract runs through you. Things don't get into your body until they cross into the bloodstream. If they're sitting in your gut, they're still outside of you. Each of us carries 3 pounds of bacteria down there that help us. They're our buddies. If they get screwed up, we don't digest properly. And it takes a long time to get the system rebalanced. This is part of us, those 3 pounds. Is this pathology? Yes, it is. But Dr. Sheldon Newman in the ADA News back in September 1990, when this material was first presented as an abstract, said, I don't know what the significance of the increased mercury resistance in monkey, gingival, and intestinal bacterial flora means. The fact that there is a bacterial resistance, what does it mean? What effect does it have? Dr. Newman is chairman of dental materials at University of Colorado Dental School. All he had to do was walk down the hall to a medical department and ask somebody what it meant. This is not a new problem. So we conclude that dental amalgam can cause a marked increase in mercury-resistant bacteria, that mercury-resistant bacteria enhance the reabsorption of mercury vapor, that antibiotic resistance is associated with the mercury resistance for the whole reason that I explained to you just now, and we want to know, does chronic exposure to mercury from amalgams, is it one of the things at the basis of the crisis in medicine today, antibiotic resistance? And if that's not enough pathology for you, what I've shown you so far, the Society of Toxicology had an annual meeting. The Society of Toxicology, 6,000 to 7,000 medical toxicologists, had a special symposium at their annual meeting on dental amalgam. And my co-author and my research associate, who's a physiologist, presented a paper on our behalf. And other papers were published by Dr. Mats Berlin from Sweden, a world authority on mercury, where he exposed monkeys to low levels of mercury vapor, levels that you would find people exposed to from their amalgams. And he used pregnant monkeys, and he found impaired fetal brain development, high mercury content in the nucleus basalis. Sound familiar? Nucleus basalis, that's where Alzheimer's is. And premature births and low birth weights in the monkeys. In rats, he found impaired fetal brain development, and he found it took longer for these rats to learn to run the maze. From levels of mercury exposure to mercury vapor that's been agreed upon by international medical committees comes from dental amalgams. Another group, Dr. Rowland from the NIH, branch of the NIH, looked at dental personnel, and he took 7,000 dental assistants and screened them to obtain 418 eligible subjects that didn't have any other problems. And he found that women who prepared 30 or more amalgams per week had a fertility rate only 50% of that. This is coming from the U.S. government. This is funded by the U.S. government, and these are government epidemiologists who know what they're doing. It's their business to know what they're doing, and they're publishing this kind of research. This stands in marked contrast to the questionnaire studies that get published in JADA, sending out the dental assistant, you know, have you miscarried, you have birth problems, or this or that. This was done in a proper epidemiological fashion. Are we surprised? No. We know we have an occupational problem with mercury. This is medical research. You can't find these things out by simple little questionnaires done haphazardly by taking a list. You can't expect dentists who come to the ADA annual meeting to pee in a bottle and then you do some calculations and say everything is fine. What do we know for sure? Dental amalgam is the major source of mercury exposure in the general population. That is scientific fact. Dental amalgam mercury vaporizes into mouth air. It also corrodes. That is scientific fact. Amalgam mercury vapor is inhaled and amalgam particles are swallowed. That is scientific fact. Amalgam mercury distributes into body tissues. You've seen the picture. That is scientific fact. And amalgam mercury alters cell function. I've just shown you 4 pathologies, and we're just getting started. But the U.S. Department of Health and Human Services came out with all kinds of things and news releases that really didn't bear any relationship to the paper. The telling comment in the document by the Health and Human Services Department was the fact that right up front they say this report is not intended to serve as an authoritative source on dental amalgam safety. Yet the American Dental Association made pretty big hay out of the fact that somebody there wrote a press release that bared no resemblance to the document. And I read the document. And if there's an honest bone somewhere, I would hope they would read the whole document and find out that all the committees didn't say there was no problem. In fact, most of the committees said that, well, all the evidence is not in, but we better be careful. Maybe we should classify amalgam. You know, amalgam's not even classified right now. But some dentists think that parts are parts. That you can throw gold, silver, tin, copper, zinc, titanium, chrome, cobalt, all in the same mouth, for the notion that somehow you're restoring this organ called the oral cavity to function. But I think we know today that parts aren't parts. And yes, I think dental amalgam is great. It's inexpensive. Excellent. It's user-friendly. True. It's durable. Yes. But is it biocompatible? The evidence that's in says no. All I want to know is how much is enough. When is enough evidence enough? I mean, we're talking about peer-reviewed medicine now. We're not talking about the California Dental Association journal. And you don't have to be a genius to figure this out. I mean, I've laid out for you experiments, ladies and gentlemen, that are really simple. I consider myself an above-average intelligent man, but I am no Albert Einstein. The thing that's profound about this research isn't the research, it's the findings. The research experimental design is something that could have been done in the 1930s. But never was. Never was. We went on saying this is a great material. And I think the choice is simple when you compare the two things. And you know, the argument that composite restorations don't last isn't even true. Because if you go to the dental literature published by these same dental materials experts, they all say now that the new composites last as long as the amalgam. Are they more technique sensitive? Yes. Do you have to put more time, skill, care, and judgment into it? Yes. Should you do no harm first? Yes. Yes. Thank you.
Got about 5 minutes. Dr. Vimy, I have a question related to your presentation on the fact that it is now determined that mercury from dental amalgam will influence antibiotic resistance. There is
You're supposed to be over there. Okay, sorry, Mike.
There is one particular disease that was virtually eradicated that Bedell amalgam not only gets into the GI tract but also is inhaled into the lungs. This is tuberculosis is a disease of the lungs. Is anybody now interested in or investigating the potential connection between the increase in tuberculosis because of antibiotic resistance and the inhalation of mercury vapor from Bedell amalgam?
Well, we've toyed with that idea, but so far, to my knowledge, Mike, I don't know of any laboratory unless you do that's actively investigating that. But we're looking here at a phenomenon, and this phenomenon not only with the tuberculosis, but with the venereal diseases, some of the bacterial ones. This could be a factor, and this may lead to us identifying other environmental factors. I don't believe that amalgam causes every disease under the sun. You see, up until about 1980, you had a debate here between two groups of people. One group said it caused all these diseases. One group said it was perfectly safe. Neither one of them had scientific data to support their position. So it was won on the basis of numbers. The guys who had a larger amount in their camp were the winners. Other people came along in medicine and started to say, well, since both of you groups don't have any scientific basis, and since mercury is a pretty toxic thing, let's do some research. Like I said, I got into it to prove amalgam was safe. That's not widely known amongst the dental community. I couldn't believe things coming out of Colorado. I thought that, none of this could be true. I mean, this is, lunacy. But you see, as you do research and it takes time, some, there's smoke, there's fire. Some of this stuff is coming to fruition now.
Question about this presentation you just made. Have you made such a presentation at FDA or EPA? Have been invited to do so?
I was invited to give this presentation to FDA. The FDA meeting that was held was not a scientific forum. It was a public forum. And our research team declined to attend that meeting because we are only prepared to discuss this issue in that kind of depth in a scientific forum. And the videotapes of the FDA meeting proved out that basically what it was an open public forum where people who were scientists and non-scientists alike got up and gave their opinion. We don't deal in opinion. Nothing I've shown you today is opinion. Nothing I've said to you today is opinion. Everything I've shown and said to you is scientifically verifiable, and the jury doesn't want to believe science. If they think animals bear no relationship to humans, that's their problem. Then they're not part of the mainstream of medicine. We have dental materials that are put on the market that we use, and when the problems arise, then they take it off the market. I want to know why these materials aren't tested before they're put on the market.
Dr. Vimy, my name is Carol Ward. I'm chairperson of the DAMS chapter, Southeast Pennsylvania. I think one important thing I'd like to ask you, you were saying that mercury is mercury, whether it's fish or beacon or whether it comes from vapor from the fillings. But it's my understanding that the vapor from the fillings causes, and when it comes into the body or bloodstream, it combines with bacteria to make methyl mercury, which is one reason why it's so terribly destructive to human health. Is that correct?
Some of that methylation occurs, but it's a fallacy that has been put out that methyl mercury is more toxic than mercury vapor. It's not. Actually, mercury vapor, according to the World Health Organization, is more toxic than methyl mercury. So you ask why all this attention about methyl mercury. The attention is because we've had the Iran problem, we had Minamata Bay, and we had some huge exposures that happen to be with methyl mercury. Mercury vapor exposure, for the most part, was thought to only be occupational. So dentists and thermometer makers and electronic workers would be the ones, and chloroalkali workers would be the ones exposed to it. But you see, now we know that what's going on is a chronic low-dose experiment in the community without anyone looking to see if there's any results.
I have another question for you. I was speaking last night to some of the people here, and they were talking about the danger of EBT accumulation cementing the mercury in the brain and being even worse for you than not having it. Is that true?
I haven't seen the work, but I understand Dr. Haley from the University of Kentucky, Saunders Brown, has shown exactly that. He's presented that work as an abstract, and I understand there's a full paper coming out.
Thank you.
But EDTA treatment, whether it causes the mercury to get tied up instead of coming out
in the brain.
Hi, my name is Renee Mauser, and I'm a victim, a recovering victim. I spent 3 years virtually in bed, invalid, with every single system of my body totally compromised. I am a nurse, and what I see is myself pretty much near death. I am now 85%. I went through removal, and I'm now just having chelation. Question, as far as antibiotic resistance, do you see any reverse in that after proper procedures, incubation. And also I was very interested as far as the sheep, the monkey study. Did you follow up and remove the amalgams and go back and see if any of the deposits were lessened? Like I said, I want to know if I'm going to get rid of it.
A, you'll get rid of it. Toxin is A, that you remove the source of the exposure. Because otherwise you're just taking aspirins for a headache. See, I mean, if you've got a mercury exposure problem and you want to treat it, you can take all the drugs and all the diet and all everything else you think is good for you, but until you get rid of the source of the exposure, your body still has a challenge. So you have to get rid of it. Okay, so that's the first question. With regards to the antibiotic resistance, yes, when you remove the amalgams, the number of mercury-resistant bacteria dropped back down to baseline, and consequently so did the antibiotic resistance drop down to baseline. But those bacteria are always present. What this shows is that the mercury exposure exacerbates a low count of bacteria that are always there that have this information, that they just sit there. They're kind of like the protective mechanism for the whole colony. And then all of a sudden the mercury comes along and they get hit, and while the other bacteria are starting to die, they're replicating as carriers. We brought the Old Testament to you, that type of thing. That's basically what it's like. And I'm not a bacteriologist, so just tell me.
It's absolutely imperative that we in the IAOMT become extremely well informed about this issue. So I'd like if I could clarify a point that just came up. Those of us who attended Mercury 101 in Orlando will already know this. Mercury vapor is not toxic. It is non-toxic. It is electrically neutral toxic. What is toxic is ionic mercury. The reason that methyl mercury and mercury vapor are considered to be the most toxic forms is because of their ease of entering the body, penetrating cell membranes. Once they get into the body, then they only become toxic when they first ionize and are attached to body tissues or ligands. So that is why Murray says, and it is true, that mercury vapor is as, if not more so, toxic than methyl mercury, but only because of its ease of entering the body, penetrating cell membrane, entering the cell tissues, and then ionizing to become the toxic form of all forms of mercury.
Dr. Vimy, I've talked to a number of researchers around the country who are doing experiments or studies of lead and mercury, but not familiar with this research. And they tend to discount this because they've seen a 60-minute story and the rapidity with which people get well when they have their fillings out, get up and supposedly dance that night or whatever. Is there any explanation for that? I mean, the basic theory of toxicity is to build up a toxic burden. To take the fillings out, you would think it would take months or years to lower that toxic burden fast enough for people to get well.
So you're asking me, can removal the next day produce
Is there any hypothesis for explaining the fact that people seem to get well rather rapidly sometimes through that source?
Well, some people are rapid excretors of mercury. The problem isn't so much that they can't get rid of it, the problem is that they get exposed continuously. And I've seen some cases in my own practice now, and I don't advocate that everybody have their amalgams out. I think that's, and I don't advocate anything more than we stop using it. I think the next generation has to be without amalgam. But yes, people can show improvements within 24 to 48 hours because they're no longer exposed to the mercury vapor, which goes directly to the CNS. So any nervous system effect can change quite dramatically almost immediately in some people. But does amalgam cause MS? I don't know. There's some preliminary evidence, but nothing definite yet. And so I'm not one of those advocates that it cures all these things. I believe it's a positive health choice. I believe that if someone is chronically ill and has a problem, that it's a positive health choice to eliminate a chronic exposure to a heavy metal. And that's what I tell people that come to me for advice. I'm not a physician, I'm a dentist. Fillings leak. Things can leak into fillings, and things can leak out of fillings. We know that amalgams leak mercury, and I think that I'm doing a dental thing when I tell people after I do a vapor test that you have readings that are far too high. Your exposure when compared to EPA standards is X, Y, and Z. That's all been worked out for you already. That's scientifically accepted in medicine. It's a medical test. In fact, I understand now in Germany they're starting to do this test routinely.
Dr. Vimy, might we point out that many times the biochemistry is also overlapped with the bioelectrical factor. When you remove a current thresholds tend to ameliorate rapidly.
Yes.
And then the chemistry threshold will follow.
I think if I learned anything from Dr. Massey this morning, or I shouldn't say learned, but he reinforced quite soundly, was the fact that you have
batteries going on that are unbelievable, and you can see all this stuff happening, and that alone. I understand that the current generated teeth is in millivolts, and I think the brain operates on nanovolts, if I'm not mistaken. And so who knows what the effects are here? You've got these teeth with posts in them and all this, having electrical patterns going through them. It's very close to the central nervous system, so who knows what's happening here. Some of these problems that get rectified may not have to do with the mercury, they may have to do with an electrical effect, or both. I agree totally.
It's a twofold factor, and the mercury is a part.
Yeah, exactly.
If you are continuing to remove amalgams and people that request to have them removed, could you give us what your recommendations would be as healthcare providers to do the same thing to minimize our continual exposure to the mercury-based?
In other words, to minimize the dentist exposure?
Yeah.
We can get, I think we should get into that in the discussion period.
Another course.
Is there any more questions? Is that okay? I don't want to put you off, but we'll get into that at the end of the day.
One question and two comments. Since you and all of us are perhaps amazed that there is not more acceptance of this so well-based research on the effects of amalgam, and since you mentioned the publication of ballots who contradicted the research, however presented at the Dental Products Panel meeting, can you tell us in dollars and cents what amalgam amounts to a year in the States, and how much less perhaps would be there in profit for the producing firms if we switch to composites?
I can't answer that question. All I can tell you is that we've worked it out, and it's extremely cost effective for a dentist to use amalgam. It's very user friendly. So from the dentist standpoint, and amalgam does have a lot of good physical characteristics. I believe in 1986, 100 metric tons of mercury was consumed in the United States for dentistry. 100 metric tons. Now, an average amalgam filling, I think, costs about $1. The same kind of filling made out of a composite material is about $7. An average amalgam filling can maybe be put in 12 to 15 minutes, I would guess, and a composite filling to do it as well would take maybe an additional 10 minutes. So the dentist can do as much dentistry per unit time as he can with amalgam. So there are some economic benefits to the dentist.
Yeah.
I don't think that's why they're not.
For the industry as a whole?
Well, I think that this issue has nothing to do with science. I think this issue has everything to do with politics and the fact that the United States of America is a very litigious society.
That's perhaps the answer to the reluctance.
Yeah, and what I'd like to do is get together with the American Dental Association and see if we can lobby the government to pass a law so that retroactively we can ensure that people who make amalgam, who have used an amalgam, will not be held liable for any new evidence that's come along. And then if the American Dental Association would be brave enough to say, look, the evidence is starting to mount, it's serious evidence, let's take it seriously and let's start to make the change, I think it would bring
mothers, for instance. Does anybody do any study on the
we have
Down's children, maybe?
Well, not so much that, but within the next few months, there's more research going.
And one last comment.
Yeah.
Then you have, of course, a very heavy burden if those people do have heavy mercury toxicity in their kidney and need this type of treatment. They usually go in kidney failure at very high rates and die from kidney failures. And I think here again is a very, very protective dimension.
That's right. That's why it's important to get rid of the amalgam. You see, the half-life for mercury in the kidney is 70 days. All right, so if someone gets rid of their amalgams, 70 days after having the amalgams removed properly, they'll only have half the amount of mercury left. And then an additional 70 days will be a quarter, and an additional 70 days will be an eighth. So the kidney can get rid of the stuff quite rapidly, but you first have to get rid of the exposure.
Yeah, but I don't think any oncologist is considering this factor.
No, but maybe you should make them aware of it.
Since time is limited, I'd like to talk this afternoon about antibiotics and the effect of it, because there are entirely different opinions too, and it's a controversy that should be beneficial.
Okay, thank you so much. Well, we'll take one more question. I hate
The rest we can save till the panel discussion later. We're going to have time for lunch.
Regarding professional occupational exposure to mercury in dentistry, an understanding that mercury accumulates in the brain, in kidney, in intestinal tract. As a practicing dentist, we want to combat some of the effects of this exposure via EMPS used as a challenge and as an ongoing procedure, and for the other modalities which again would be protective and beneficial.
Yes, sir. Not so much of the question that was asked just a little while ago, that there are a lot of measures you can take. Number one, wearing special mercury vapor masks to protect you from the vapor. And some of these challenges are good and fine. Eliminating mercury from your practice so that you're not removing it, that type of thing. But
This regards in or exposure, just as we do practice.
all right. The whole body, I can only tell you from a scientific perspective, because I'm not a physician, the whole body half-time for mercury is about 74 days. But there are compartments that are much, much longer. For instance, the brain tissue has been known to hang on to mercury for as long as 10 years. So doing all these things and these challenges will increase the rate of mercury release from a lot of tissues, but you still have the central nervous system tissue that has a problem. And you see, it's very slow to release the mercury, because once it crosses the blood-brain barrier and gets into the tissue, into the neural tissue, it's very difficult. But you need proper medical supervision for that. It's not my place to recommend treatment. I think that there are enough physicians out there in toxicology that can probably handle it. I can't, so I can't tell you much more than that. Okay.
Just one quick question. If filling, the dentist that I talked to said that he couldn't replace the amalgams because they were back teeth, they were too large a span, and the only recourse he offered me was gold. What about substitutes?
Well, I think the previous author said, the previous speaker said quite clearly that he felt that no metal was the best. But the new hybrid composites now, they're making full crowns out of it. Are they as durable? No. All right, they're not as good as some of the materials. And see, the issue is not wear resistance. That's a dental thing. How well does it last? How does it wear? The issue here is biocompatibility. So you can make just about anything you want out of a good composite within limits. Will it last a lifetime? No, nothing does. The statistics on crown and bridge made out of gold and porcelain is that on average they only last 10 years. Well, the amalgam only lasts 8 years. So I mean, that's the scientific dental statistic on crown and bridge.
We're going to break for lunch now. We will be starting back in an hour, 1:30. We'll be back sharp. You don't want to miss the next few. Thank you. Bedell. Many of you know of him, and Berkley was a U.S. Air Force pilot during World War II, and as a kid accumulated about $50 from his paper route and parlayed that into what has become the largest and probably most well thought of fishing tackle company in the world. And Tony Martinez was here this morning under duress because he was supposed to be up there watching his wife as she was about to deliver a baby anytime. To have an angler like Berkley giving up fishing in Florida to come up here is really a testimony to something. And I really appreciate his being here. He was the nation's first small business person of the year. He served as a congressman in the United States House of Representatives from Iowa from 1975 to 1987 when he retired. During that period, he served he was the subcommittee chairman on the Agriculture and Small Business Committees and was the president of the House Prayer Breakfast Group. Berkley Bedell is probably the one moving force, the prime moving force behind National Institutes of Health formulating the Office of Alternative Medicine, he along with his protege, Senator Tom Harkin. And he is also serving currently as a member of that advisory committee.
Thank you, folks. Can you hear me all right? If at any time anybody can't hear me and wishes they could, you can raise your hand. First of all, I've got some good news for you people that are interested in alternative medicine, because we have such a small amount of it, it seems like, that we ought to hear about all that we can. I don't know if any of you have heard before about Dr. Robert Rowan in Alaska. He's been a great promoter of alternative medicine, and he was nominated to be on the Alaska State Medical Board of that state, and there was tremendous opposition to him. I can read to you here Alaska State Medical Association Chairman Donald Lehman, MD, urged the membership to block Robert Rowan's appointment, calling him, and quote, an anti-science practitioner and a, quote, an outspoken proponent of alternatives whose practices include cleansing the blood and intravenous injection of hydrogen peroxide. And there was tremendous movement, but just a few days ago he was confirmed, and he is now on that board in spite of that opposition. You know, it's really sort of ridiculous for me as a layman to come before you dentists and doctors and talk to you about health. But I'm qualified. Because I'm more than just a layman. You see, I'm a politician. And we politicians are supposed to know everything about everything and convince people of that. And the sad thing is we frequently convince ourselves of that as well. So without any apologies, here I am to tell you what I believe is wrong about our health system and what we should do about it. Rich has told you a little bit about my history of starting my company when I was 50 years old. When I was 15 years old. But when I was 50 years old, my wife and I started to look at our lives and decided we'd like to do something more rewarding than simply building a bigger and bigger fishing tackle company and have the world cheer what we were doing. So we literally spent a year looking around to determine what it was we wanted to do with the rest of our lives. And one of the things I did when I made that decision that we wanted to do something different was I decided I wanted to become active in politics. I had no idea in the world of running for office. That crossed my heart. But I went up and changed. As I looked into it, I decided, I'd been a Republican all my life. I decided that I wanted to become a Democrat. And on my 50th birthday, I went up and changed my registration to become a Democrat. I tell everybody I figured I would be a Republican for 50 years and then a Democrat for 50, and then I decide which I liked the best. In all seriousness, this was not a joke, in all seriousness, my mother said she thought she'd have to move out of town. She had been actually the top Republican woman in the state of Iowa in our community, almost had no Democrats in it, and it was quite a shock. So as I looked around at what I wanted to do and this, that, and the other things, finally I did decide that I wanted to run for United States Congress. So I had a poll taken. The pollster said, don't run, you don't have a chance. So that convinced me for sure that I should. And so I went down to the district Democratic Convention, first convention I'd ever attended. As well known, our family is very active Republicans, and I announced that I was going to run for the United States Congress as a Democrat. I not only came from a family of Republicans and that sort of thing, but at that time, labor was a very, very major constituency in our district. And I had a non-union factory and had been active on the right to work law committee. So you can imagine the reception that I received when I came down there and told the Democrats that I wanted to run for Congress. Well, the reality is that it was so hopeless to run for Congress in our district that I didn't even have any opposition in the primary. And my wife and I worked real hard that whole campaign and surprised everybody. We got 49% of the vote. And the next 2 years I came back and I was indeed elected to Congress. And there's a lot of exciting things I could tell you about that term, that period that I served in the Congress. But I want to mention one because it's one of the things I'm so sorry that I didn't do. Rich already mentioned that I was chairman of an agriculture subcommittee. I was chairman of the agriculture committee that had to do with the FDA. It was the committee that had to do among other things, the application of insecticides and pesticides and chemicals and those sorts of things. And when they appeared before us, they testified that it took 7 years and $7 million to get approval to sell a chemical that killed crabgrass. And it took more time and more money to prove that it killed crabgrass than it did that it was safe. And I said at the time, I said, well, you ought to have to prove that it's safe, but it's ridiculous to have to go through all this effort to prove whether or not it kills crabgrass. I said, if it doesn't kill crabgrass, people are going to quit buying it anyway, and the market will take care of it.
And I said at the time, I said, I hope we never get in the situation where you can't sell a fishing lure unless the government has checked and said, yes, we decided that it caught fish. The sad thing is that I think I very likely could have gotten that law changed if I had pursued it. But you're doing a million things in the Congress, and nobody else seemed to have any interest. So, and I didn't do it. And I look back now and I say, what a change it might have made in the attitude towards how the FDA treats healthcare as well, if I had gone ahead and done that. So it was one of the sad things that I tell you about one of my failures in life as we're starting to talk about those things. Well, after my 12 years in Congress, I was fishing down at Quantico Marine Base, and there were wood ticks. I walked through the grass, bit by wood ticks. I came down with Lyme disease, and it was bad enough that I retired from Congress because of that. I did 3 times with very, very, very heavy doses of antibiotics, or they'd run it into your veins. And each time I'd get a little better, and then I'd be bad again. Finally, I turned to an alternative treatment, and I was cured. Now, the sad thing is, I can't tell you about that treatment, because if I did, somebody would probably get into difficulty. And what a sad thing, if I'm right and it really is true, that when people call me, I can't tell them what happened to me in regard to my Lyme disease. I also had prostate malignancy shortly thereafter. I went through what would normally be the case. I had my prostate removed. They didn't get it all. I had radiation treatment for 6 weeks. And 2 years, as a result of what I'd seen with my Lyme disease, I became very active in looking into these different alternative types of treatment for disease. And as a result, in that effort, I went up to see Gaston Maisons in Canada. His stepson Stephen is here. Stand up, Stephen. People ought to at least know who you are. Gaston claims that he can, by looking at your blood, detect oncoming malignancy for as much as 18 months before you have any symptoms. And he looked at my blood and he said, yeah, he said, you've got that coming back on you. Now, I can't be sure that's right. I believe him. I'm confident it's true. But he said, I think you really should go ahead and take his treatment. His treatment consists, Gaston claims that the organism that causes malignancy has a tremendous affinity for nitrogen. And it robs your immune system from the nitrogen it needs to function effectively. And his treatment is an injection into your lymph glands of a chemical that will flood that area with nitrogen so that it can function effectively. And so I, as a result of that, I went down to Mexico, had them show me how to inject it, bought the 714X from them there in Mexico, that clinic, and injected myself for 21 days in that area. Went back to see Gaston. He looked at my blood. He said, no, it's clear now, but I think you ought to do it for another 21, which I did. And all I can tell you is now that all of the tests I have had certainly indicate that I have no trouble with my malignancy, and that was better than 4 years ago. As a result of that, I'm a great proponent of that treatment as well as many others. And as I have become deeper and deeper involved in investigating these alternative treatments, I've been shocked at what I have found. The perception exists that scientific medicine, such as we have here in the United States, is way ahead of all the rest of the world. And that practitioners who use these alternative methods are just a bunch of quacks. Sincere group of scientists and practitioners who I believe are working with science and treatment who hold great promise for our society, and they're completely shut out of the system. And we have a system which tends to make a criminal out of anybody who tries anything new in the practice of medicine. So what do we have here in the United States? We have the most expensive health care system in the world. In 1990, we spent 12.4% of our gross domestic product on health care, about twice what they spend in England, where they have universal health care. Japan's universal system costs 6.7% of GDP, compared to our 12.4. Germany spends 8%, Canada and France 9%, and all of them have universal health care for everyone. And we rank behind most of them in measurements of health, such as life expectancy and infant mortality. So what's wrong with our system and what do we need to change? And I would argue that we're basically on the wrong track in regard to how we treat disease. The time was when the main health threat faced by our ancestors was communicable infectious disease, such as typhoid fever, influenza, syphilis, scarlet fever, and the like. And two things happened. One thing is they cleaned up their sewage system and garbage disposal and their water system. The other thing is that antibiotics were discovered. And a big debate developed between two scientists at that time, Louis Pasteur and Antoine Beauchamp. Pasteur claimed that disease was caused by a single germ that invades the body from the outside. And Pasteur claimed that disease came from organisms that are in our body that are able to change and take advantage of a weakened immune system and this sort of thing. In my opinion, both of them were right, but both of them were wrong in not also recognizing that the other one was right. Surely it's true that mumps and measles and chicken pox and this sort of thing are communicated from one person to another in our particular disease. And medical science has made great progress in finding pharmaceutical cures for these communicable diseases. And they made so much progress that at this time, almost all scientific research is headed in that direction. And the idea is find out what causes the disease, then find out a drug that will kill the germ in a test tube, and then we will administer to the people. And very little concern as that's administered is what that drug is doing to the people that they're treating with the drug. The problem is that at least I believe Beauchamp was also correct in that there are also organisms that are capable of changing forms from non-pathogenic to pathogenic forms depending upon the environment in which they find themselves. This is called pleomorphism, and it's not yet accepted by mainstream medicine, but there's growing evidence that Beauchamp was also correct. Indeed, just a week ago yesterday, I was up at Gaston Naissance, and he showed me a video where you could actually see one of these organisms changing form under his microscope in this video. So, what's happened? Well, typhoid, scarlet fever, and other infectious diseases are no longer our main health problems. They've been replaced with cancer, heart disease, Alzheimer's disease, arthritis, MS, and the like. And few people would argue that cancer and heart disease and arthritis and Alzheimer's are diseases that we catch from somebody else. But because they work with infectious diseases, we still try to find pharmaceutical drugs to treat these degenerative diseases. And how could we possibly do such a foolish thing? Well, I would argue it's because of our system. I would argue that it's not because of the bad pharmaceutical companies or the bad doctors or this sort of thing. I think it's because of the system that we have. And it starts with our medical schools, where the students are taught that, first of all, that Pasteur was correct, and secondly, that this is the pharmaceutical drug you use to treat this and this and this and so on down the line. And secondly, I would argue that our medical doctors are taught how to treat you when you're ill and not how to keep you from becoming ill. We don't have a health care system in our society. We got a sickness care system. Try going to your doctor when you're well. What he'll tell you, he may tell you to worry about your heart, your cholesterol, or your blood pressure, or that sort of thing, and that's it, and come back again when you're sick. And those doctors aren't bad people. As I said, the whole problem is how our system operates. As I said, they are taught in medical school what pharmaceutical drugs to use for the patients. And then pharmaceutical drug companies give them their free samples. They advertise in their periodicals. And doctors are required to take continuing education. Who do you think puts on these seminars for them where they go off somewhere for a retreat for continuing education? You know, it's the pharmaceutical companies that are doing it. And that's probably what I would do if I were running a pharmaceutical company and wanted to sell more pharmaceuticals, just as I did when I wanted to sell more fishing tackle. And that's why I say that it's all the way the system is done. So I found large numbers of these non-toxic treatments that are completely frozen out of the system, and you ask yourself, why under this circumstance? First of all, it starts with the Food and Drug Administration. A study was done at Tufts University. He spoke to you, didn't he? Sure. The fellow from Tufts University that had done the study early this morning. In any event, it was a study done at Tufts University as to what the cost was for developing a new drug and having it approved by the Food and Drug Administration. It's $230-some million to do that. So I called him on the phone and I said, well, what does it cost? Are you the gentleman back there? Yeah, okay. Yeah, I called and talked to you on the phone. And I said, what is it just for getting it through the Food and Drug Administration? I said, I don't want to know the cost of developing it just through the Food and Drug Administration. Well, he spent a little time going through the figures, and he told me it was $130-some million. Now, I think he thinks it may not quite be that now, and I'm not here to argue that, but it doesn't really matter. It doesn't matter if it's $20 million or $200 million. The fact is the only people that have the money to do that are the pharmaceutical houses. So what have we done? We've given them an absolute lock on the market as far as medicines are concerned. And believe me, the Food and Drug Administration is vicious in attacking anybody who uses an unapproved drug. So if I'm correct that pharmaceuticals are great for infectious diseases, but are not that effective for the degenerative chronic diseases, which are our main problem today, how could we possibly be so stupid as to give exclusive rights to the people that make the medicine, which is what you should have used in the past, but it's not the type of medicine that is going to be the most effective today? Secondly, I would argue that this tremendous cost of getting approval to market a product absolutely guarantees that we're not going to get any low-cost medicine into our system. A consumer in the United States spends $400 to purchase pharmaceuticals. It would cost $159 in Belgium, even less in Mexico. Drug costs are 32% higher in the United States than they are in Canada. And so I have a proposal. The proposal that I'm starting to talk to some of my colleagues in the Congress is that we would pass a law which would read as follows. Any person shall have the freedom to be treated by whatever treatment that person desires, and no practitioner shall be prevented from or punished for administering such treatment, provided there is no evidence that such treatment poses a serious danger to the patient, and the patient has indicated in writing the desire to be so treated. Provided further that the patient would have to be fully informed of the contents of the medicine or treatment, together with any possible side effects. I would also be perfectly glad to add to that would even increase penalties for anyone furnishing false information or claims on any treatment or medicine. I can't imagine how we can have a system where if I had terminal illness and I was sent home to die by the doctor and said there's nothing we can do for it, and I knew somebody who had gone to Mexico and been effectively treated and I didn't have the money to do it, that I would not be able to get that treatment for myself. And the government say, no, I'm sorry, you can't have that. As far as I know, this is the only area in our whole society where the government tells you you cannot do something if that something is not of harm to any individual or anything. We let them smoke. We admit it's dangerous. We let them drink alcohol. We let them gamble. We let them do all sorts of things. But we say, no, I'm sorry, you can't have any other treatment except the treatment that has spent millions and millions of dollars in order to get our approval, in order to be used. You see, I wouldn't even change the FDA. My proposal is that the FDA operate just like the underwriter's laboratory. Any of you acquainted with how that is? Well, underwriter's laboratory is a laboratory that checks electrical equipment. Neither approves it or not. And you can sell electric equipment that has not been Underwriters Laboratory approved. But if you're going to build a house, you sure better be sure you put UL approved material in it if you want to get insurance. So I think it would still work like it does. And I think the insurance companies probably still would only pay for things that have been approved by the Food and Drug Administration. That doesn't bother me. It would be tough for a while, but at least it's my belief it wouldn't be very long before the insurance companies would find that some of these treatments are both more effective and less costly, and they would start paying for them. And at least we'd give the people the opportunity to use those things if they wish to do that. So I talked to some of my colleagues about this proposal. It's only been recently I've started to do it, and I get two reactions. Some of them agree and say that what I say makes a lot of sense. In fact, one of my colleagues in Congress said, well, the trouble is it makes too much sense, what you're proposing. Others say, well, that sounds pretty good, but they're worried about quackery. My argument is that we already have strong impediments to quackery. One of them is we already have laws against fraud and against false claims and this sort of thing, and I'd be willing to strengthen those. And the other is a malpractice situation with which you're all so well aware. And secondly, I would argue we already have in the system the way it is legitimate quackery on a large scale. We have doctors running tests that are not needed and collecting insurance for them. We have doctors administering treatment of questionable value. I'm going to have to do some reading here in part of this. There was a small but very important book that was published in Germany in 1990 in Stuttgart. The 92-page document reports the results of an exhaustive statistical analysis of the worldwide literature, several thousand articles, on cytotoxic chemotherapy in the treatment of advanced epithelial cancer. Epithelial malignancies are responsible for more than 80% of cancer mortalities in the world and include lung, breast, stomach, colon, pancreas, bladder, liver, ovaries, cervix, trachea, bronchus, rectum, esophagus, head, and neck. Tumors are considered advanced if they are recurrent, disseminated, or are not radically resectable. The main non-epithelial malignancies, such as lymphomas, leukemias, and sarcomas, are not part of this analysis. The author, Ulrich Abel, PhD, is a highly regarded cancer epidemiologist and biostatistician from the prestigious Heidelberg Tumor Institute. An indication of the thoughtfulness of Abel's approach is found in the book's preface. Abel based his conclusion not only on published material, but on about 150 replies to personal inquiries he sent to over 350 oncologists and research units around the world. The inquiries specifically addressed any unpublished data or any other data that would contradict his findings. Abel's conclusion is stated in the first page of the preface, and I quote, "There is no evidence for the majority of cancers that treatment with these drugs exerts any positive influence on survival or quality of life in patients with advanced disease." Let me go through a few of them. Non-small cell lung cancer. In 10 randomized trials comparing chemotherapy and radiation to radiation alone, none showed a survival advantage in combination therapy. Colorectal cancer. There is no evidence that survival is improved by chemotherapy. Gastric cancer. There is no clear evidence that chemotherapy prolongs the survival in advanced gastric cancer. Pancreatic cancer. The treatment group had a shorter median survival than the control. Breast cancer. Further comparisons, including periods pre and post chemotherapy, showed no survival improvement. Cancer of the cervix. There are no indications from randomized studies that have been done that survival is improved with chemotherapy. Head and neck cancer. There is no evidence of survival benefit from chemotherapy. He goes on to say, virtually all chemotherapy trials emphasize response to therapy in the form of tumor shrinkage as a measurable endpoint defining success. There is no doubt that in many and sometimes the majority of patients, chemotherapy shrinks tumors, at least initially. However, this is not a good predictor for survival, and the assumption that a response to therapy prolongs survival is not supported by clinical studies. One of the most interesting and perhaps disturbing findings by Abel is his reference to polls showing that many oncologists would decline chemotherapy in their own case. He goes on to say, perhaps Abel's most compelling comment in this concluding chapter was the following regarding non-chemotherapeutic approaches. For an outsider, it must be incomprehensible why therapeutic concepts that have shown antineoplastic effects in animal experience for decades and whose anti-cancerous effects in man are documented by promising preliminary evidence are not examined in controlled clinical trials. The concentration of the majority of patients and medical capacities on chemotherapy trials might turn out to be an erroneous track with serious consequences. Is it any wonder that people are starting to rebel in our system? And then there was a special article in the New England Journal recently by David Eisenberg, who is a friend of mine, and he did interviews with 1,539 adults in a national sample, and the results were as follows. 1 in 3 respondents, 34%, reported using at least one unconventional therapy in the past year, and a third of these saw providers of unconventional therapy. The average cost was $27.60 per visit, and the highest use reported was by non-black persons from 25 to 49 years of age who had relative more education and higher incomes. An extrapolation of the United States population suggests that in 1990, Americans made an estimated 425 million visits to providers of unconventional therapy. This number exceeds the number of visits to all U.S. primary care physicians, 388 million. And so we see people starting to take advantage. We see increased use of vitamins and minerals and supplements. And we see more and more studies showing that these items seem to be effective in many circumstances. We see that in many situations there seems to be some advantage in taking more than the recommended daily requirements of these items. I'd like to read to you from a couple more articles, if I may. In one of the most, this is from the Wall Street Journal, not exactly a radical sort of a publication. In one of the most important studies, researchers in Brigham and Women's found that women who took vitamin E supplements totaling at least 100 IUs daily for 2 years had half the risk of cardiovascular disease as the women who hadn't taken supplements. In a study reported last November in the British journal Lancet, researchers in Canada found that elderly people given modest supplementary doses of vitamin E, beta-carotene, and some other vitamins and minerals for a year had half as many colds, flus, and other infectious illnesses as a control group given a placebo. And when those subjects did get sick, they got better twice as fast as the members in the control group. And I could give you any number of such tests. So I happened to talk to a good friend of mine, Senator Tom Harkin, who happens to be subcommittee chairman of the Health Appropriations Subcommittee of the Senate, and I told him my story, and we talked about it. And so Tom put $2 million into the NIH budget for an office of alternative medical practices, and the legislation provided for an advisory committee on which I served. And what I'm trying to get this office to do is to do some outcomes research. What I'm trying to get them